Hello everyone. So today we are going to discuss multiple sclerosis. So from our last video, if you remember, we discussed about motor neuron disease. So in contrast, if you remember motor neuron disease, we discussed about SOBBC. Okay. So S for sensory, O for ocular, B for bladder, another B for bowel, and C for cognitive. So we discussed in motor neuron disease that in motor neuron disease, this sensory system, ocular system, bladder, bowel and cognitive, they are spared. They are not affected. But what will happen if these five genres, these five systems are affected? So when these five systems are affected, we call them as, in a group of, these are a group of symptoms, we call them as multiple sclerosis. So what happens in multiple sclerosis? There is involvement of sensory system, the ocular system, bladders, bowel and cognitive system. So let's try to find out what are these clinical findings in multiple sclerosis related to these five systems. So in sensory part, pain is the most important part in multiple sclerosis. Yes, this is a remitting and relapsing, but there will be pain will be there. Pain is very important in sensory part. Plus there will be always some tingling sensations. Some tingling sensations like pin and prick, needle sensations, like pin, prick, needle sensations, then tingling sensations, and there are some unpleasant sensations, unpleasant sensations. Like feeling of wrapped up by a blanket, something like unpleasant sensation, like warm, wet sensation, this type of unpleasant sensations are felt in sensory thing, and grossly we call them as, there is so in pain we call the paresthesia is very common. So paresthesia is found in the sensory part. In the sensory part there will be paresthesia. Then coming to ocular, in multiple sclerosis there will be optic neuritis. Okay, there will be optic neuritis. There will be optic neuritis. So as a result of optic neuritis, there will be unilateral blindness sometimes, or diplopia, that is double vision, diplopia. Sixth nerve palsy will be there. Sixth nerve palsy will be there. So because of sixth nerve palsy, there will be diplopia, double vision, that is double vision, and there will be decreased visual acuity. Decreased visual acuity, color perception is lost or decreased. There will be decreased color perception, and there will be difficulty in vision, sometimes blurring of visions. All these are associated with optic neuritis. Then in the bladder there will be detrusor hyperreflexia. The bladder, the urinary bladder, it is hyperstimulated. This is detrusor. The musculature of the urinary bladder is called detrusor. So there will be detrusor hyperreflexia. So what will happen if the whole urinary bladder is contracting more? There will be incontinence. There will be incontinence, and because of detrusor hyperreflexia, there will be increased frequency in micturition, and the patient cannot hold the urine, and it often goes out while laughing, or that is called stress incontinence. While laughing or while coughing, the urine may leaks out. We call it stress incontinence. So that is the bladder involvement here. In the bowel, there is occasional constipation. There will be constipation. And there will be indigestion also. Indigestion, difficulty in absorption. But basically we are concerned with constipation is very common in multiple sclerosis. Then in cognitive, we know in motor neuron disease there is no involvement of cognition. But in multiple sclerosis there is cognitive involvement. As a result, there is memory loss. Depression is common. Depression is also common. And basically in multiple sclerosis, because the corticospinal tract is also involved, so there is So there can be difficulty in execution of movements, difficulty in execution of voluntary movements goes down. The execution of voluntary movements goes down. So apart from that, you have to know that in multiple sclerosis, the pyramidal tract is involved. Which part of pyramidal tract? That is often asked in the question. That is the lateral corticospinal tract. So lateral corticospinal tract are those tracts that cross to the opposite side. Okay. So let me do it here. So lateral corticospinal tract in the medulla, they cross to the opposite side. So these are lateral, 80% of fibers of corticospinal tract, they cross to the opposite side. So they are called lateral corticospinal tract. So often in multiple sclerosis, this lateral corticospinal tract are involved. As a result, it is in multiple sclerosis, there is upper motor neuron type of paralysis. So because of involvement of upper motor neuron type of paralysis, in multiple sclerosis, yes, there will be spasticity. There will be often spasticity will be seen. Spasticity will be seen. Spasticity means when there is pulling of muscles, means there is increased resistance. When there is passively we are trying to flex, there will be increased resistance. So spasticity will be found in multiple sclerosis, and plus along with that there will be increased reflexes, and there is Babinski sign positive. Don't forget that. So Babinski positive. So Babinski positive, increased reflexes, spasticity, they are upper motor neuron lesions, and so in multiple sclerosis, along with that, this SOBBC, along with that you will find some upper motor neuron lesions also. We have some ancillary symptoms which the patient feels. Now remember, these are symptoms, these are not signs. So these patients, they complain. Like very commonly this asked in MCQ is Lermitz. Remember, Lermitz symptom is not a sign. Make sure you correct it when you appear for exam. Make sure you don't write it sign. Lermitz is not a sign, it's a symptom. So the symptom is when someone complains of like electric-like sensations passing to the back. Okay, up to the from the upper back up to the lower back, they complain of electric-like sensations whenever they move their head or the neck. Okay, so that is the typically sensations. Okay, that is not a sign. That's a so Lermitz, when you write Lermitz symptom, and another is that Utrov symptom. So patient often complains of blurring of vision. Okay, so when they do any sort of exercise or taking shower, they are complaining of unilateral blurring of vision. So that is called Utrov symptoms. Okay, unilateral blurring of vision triggered by exercise, or most of the time they complain when they are taking shower, and after the shower they complain of unilateral blurring of vision. So that is called Utrov symptom. So these are ancillary symptoms because they are not signs. Remember, when you very commonly it is you write it Lermitz sign. That's a typical mistake. Students do it in the exam. Lermitz symptom and Utrov symptom. All right. So these are basically clinical signs and symptoms. Other than that, like compared to motor neuron disease, when cranial nerves are usually not involved in motor neuron disease, but in multiple sclerosis, trigeminal neuralgia, nerve number 5, trigeminal neuralgia. Okay, so nerve number 5, causing trigeminal neuralgia is involved. Facial paralysis or Bell's palsy kind of thing involved, and glossopharyngeal neuralgia. So 5, 7, 9 cranial nerves are involved in multiple sclerosis. Okay, along with that, because we know that in the corticospinal tract, especially the lateral corticospinal tract, so lateral corticospinal tract are those fibers that cross to the opposite side in the medulla. They cross to the opposite side. 80% fibers of the pyramidal tract coming from the brain, they cross to the opposite side, and 20% goes to the same side. So we are talking about this. So most of the time they are involved, causing paresis. So weakness of the muscles is one thing that is found commonly in multiple sclerosis, because 80% of fibers, they cross to the opposite side. So along with trigeminal neuralgia, facial paralysis, glossopharyngeal neuralgia, there is involvement of lateral corticospinal tract, which resulting in weakness of the muscles. Okay, and it is progressive. Most of the time it is progressive. So why it is progressive, we discuss in pathophysiology. But this involvement of lateral corticospinal tract, it results in weakness of muscles. Okay, what we call it paresis. There is progressive muscular weakness. Okay, and it is, and there is no atrophy. Make sure there is, you don't write atrophy like motor neuron disease. So there is progressive muscular weakness because of involvement of lateral corticospinal tract. Okay, so as a result, you will get some, because this is an upper motor neuron, you will get some upper motor neuron signs. Okay, so these are in nutshell about the clinical features. Now let's try to understand what is the pathophysiology. So when we discuss pathophysiology, we divide it into four things. Okay, so what are the pathophysiology? So pathophysiology starts with inflammation. There is inflammation, then there will be demyelination, then there will be gliosis, then there will be, after gliosis, there is very important, do remember, there will be conduction block. Okay, we'll discuss that thing, conduction block. And when there is gliosis, gliosis means the proliferation of the astrocytes. Okay, gliosis means when the astrocytes, which are star shaped, they proliferate, they increase in number, So when there is gliosis, there is the thickening of the white matter, okay, in the brain. So that thickening is called as sclerosis. So this results in sclerosis. That's why the disease is called multiple sclerosis, because of gliosis. So when you discuss, when you write down your answer in your examination paper, you write in this form. There will be starting of inflammation, we'll discuss in details, and then it's followed by demyelination, and then there will be gliosis, and then there will be conduction block. So this is the result of all the progressive thing, progressive muscular weakness. Okay, we will go to it one by one. So what happens in inflammation? We start with inflammation. What happens in inflammation? So we know that there is the blood vessels, it is the blood vessels, and there is a thick blood-brain barrier. So as a result, usually they cannot pass to the brain parenchyma. So here in multiple sclerosis, this blood-brain area, this blood-brain border is disturbed. This blood-brain barrier is disturbed. So what happens? There is disturbance of blood-brain barrier. So as a result, there is inflammatory cells, okay, basically T lymphocytes against MBP. This is asked in the exam. Okay, these are myelination basic protein, MBP. So they are T lymphocyte directed against the myelinated basic proteins. So what escapes through the blood-brain barrier is the T lymphocytes. So the T lymphocytes will direct against the myelinated basic proteins. We know there is the axon, and so cell body and the axon. So here there is the myelination. So this part is the myelination. So who provide the myelination? We know that is provided by the oligodendrocytes. So oligodendrocytes, they provide the myelination. So now here T lymphocytes are in the scenario, and they are causing, so T lymphocytes are here and they are causing destruction of these oligodendrocytes. They are causing destruction. Apart from that, there are also some few antibodies, they also escape. So from here there will be also some antibodies, okay, antibodies which are directed against this neuronal sheath, which are directed against this myelin sheath. So what happens here? So the myelin because of the inflammation, what happens? There is a development of lesion. Okay, so there will be lesion, multiple lesions, which gradually forms into plaque. But what is the core problem here? Core problem is that this entire myelin sheet are destroyed. So it means because of the destroying of this myelin sheet, the axon becomes typically, this is the cell body with the axon, they becomes totally naked, you can say. There is no myelin sheet. So when there is no myelin sheet, no saltatory conduction. Okay, so we can write like this: no myelin sheet, resulting in no saltatory conduction. So you know what is saltatory conduction. Saltatory conduction when the action impulse jump from one node of Ranvier to the another node of Ranvier. But here these myelin sheets are destroyed. Even the oligocytes are destroyed because of the inflammation and the antibodies coming out of the blood. They are typically directed against this myelin sheet. Why there is, we don't know exactly. The reason is still not clear. But this is an autoantibody reaction also. There is antibodies coming and destroying the axons. There is the T lymphocytes which is coming and they are calling the T helper cells and starting a flare of inflammation. So there is inflammation and there is lesion. There is inflammation and lesion. So ultimately what happens? So because of the inflammation, so what happens? There is lots of inflammation all around in the white matter. Remember, multiple sclerosis is a disease of white matter. Okay, so in the whole brain parenchyma, what will happen? There will be multiple plaques. Okay, there will be multiple plaques. Okay, in the brain parenchyma, there will be multiple plaques, which are often seen in MRI. Okay, what are these plaques? Plaques are means in the white matter. This is the white matter, right? This thick part is the gray matter, and these are the white matter. So in the white matter, there is inflammation. There is full inflammatory reaction. The T helper cells are there. There is T lymphocytes are there, which are destroying the own cells, and there is a development of a lesion, and ultimately that becomes a plaque. Okay, so white matters are destroyed. And what happens when there is destroying? There is demyelination. Now this myelinated nerve becomes naked. So the nerve impulse is traveling at a slow rate. That is resulting in the weakness and all the clinical signs and symptoms, because the impulse is traveling in a slow rate. Plus what will happen here? Along with the neurons, what will happen here? Because there is the formation of plaque. So along with plaque, there is proliferation of astrocytes. Now lots of astrocytes will come into the scenario. Lot of astrocytes. Astrocytes is proliferate. So when there is astrocytes proliferate, we call it as a gliosis. Okay. So as a result, there will be gliosis. So because of astrocytes proliferation around these inflammatory areas, there is astrocytes proliferate around these inflammatory areas in the white matter. So now you can imagine that when there is plenty of astrocytes coming in that area of the inflammatory areas, what will happen ultimately? Ultimately the whole area will become, this part will area become little bit thick than the normal, thicker than the normal, you can say. So that thickness we call it a sclerosis. So there are multiple sclerosis in the brain parenchyma, in the white matter. Not one, there is multiple. That's why we call it a multiple sclerosis. So that is the pathophysiology. But we are still not done. So there is inflammation, then there is demyelination, then there is gliosis, and don't forget it's a very important thing, that is conduction block. Because of that, all the pathophysiology or the whole clinical features are explained. Okay, let me explain the conduction block in a little bit depth. So we know this is a cell body and this is axon, okay, and this is terminal bulb and These are dendrites. Okay. Now we know there is, normally it goes in saltatory conduction, but now there is no egg, okay, but because of this myelin sheath. But in multiple sclerosis, we know there is inflammation and there is demyelination. So there is demyelination. Okay. So let me zoom this part. Okay. Let me zoom this axon. So let me make a zoom this axon. Okay. So this is the axon. This we have zoomed this part. So normally here in the depth there is potassium channels. So potassium channels are deep inside these axons. Potassium channels. What are these? They are potassium channels. So what happened here in multiple sclerosis? There is demyelination. So the myelin raft, that is the myelin raft, it has been removed. So when the myelin raft is removed, these potassium channels are more exposed. So these potassium channels are more exposed. So when the potassium channels are more exposed, there is opening of the potassium channels. So what happens? Because of the exposure of the potassium channels, okay, let's take it, you can imagine this is a cell membrane and these potassium channels are now widely exposed and open. So as a result, potassium goes out. Potassium goes out. So this creates a state of hyperpolarization. Hyperpolarization. Say for example, normally in a cell, resting membrane potential suppose is minus 70 millivolt. But if this cell loses lots of potassium, then the required normal, it may go up to minus 90 or minus 100. Okay, let's assume it may have gone up to minus 20 millivolt. So resting is minus 70, and because of losing of so many potassium, it has gone to a hyperpolarized state, minus 120 millivolt. So when there will be a moment that it has to become depolarized, this hyperpolarized cell cannot easily become depolarized to shoot a nerve action potential. So because of hyperpolarization lying in this open exposed axons, you can see this, most of the potassium channels, they have gone to hyperpolarized state. So because the myelin sheath has been removed and they are exposed and potassium leaks out and it creates a hyperpolarized state. So as a result, now we know for the nerve impulse to travel this way, we need depolarization. But here the potassium channels are hyperpolarized, already hyperpolarized. So because of the hyperpolarized nature, the nerve impulse cannot travel, not in saltatory conduction, even most of the time the nerve impulse cannot travel in this way. They cannot travel easily this way. Okay, so this feature is called conduction block. Though it is repaired, gradually it is repaired by oligodendrocytes, but multiple sclerosis is a progressive disease, and soon in the disease, these oligodendrocytes are destroyed. So repairment what is the rate of repair? The rate of repair always goes down and down in every year, every coming years. So the whole thing is that, okay, there is inflammation. Yes, there is inflammation. And then, okay, so let me summarize it now. So there is inflammation. There is inflammation, which is followed by demyelination. Okay, then it is followed by gliosis, and there's sclerosis. So demyelination, as a result there is conduction block. So because of this conduction block, now we discussed why there is conduction block, because of presence of hyperpolarized potassium channels. Okay, so how come the potassium channels become hyperpolarized? Because they are now overexposed because of the removal of the myelin sheath. So there is conduction block. So nerve impulse cannot travel in a normal rate. So the muscles, they are not getting the nerve impulse from the brain in a faster rate. Okay, so this whole conduction system is affected, and that's why there is memory loss. That's why there is the muscles, they become weak. Okay, all the ocular symptoms are affected, peristalsis is affected, bladders are affected, everything is affected because of this whole concept of the conduction block. So because of this conduction block, yes, that's what I told you, this conduction block will be repaired gradually, but in coming years this repairment goes down and the conduction block goes high. Okay, the balance is it totally disturbed and conduction block goes more and more. That's why it is progressive and it is relapsing and remittent. Remember, multiple sclerosis is relapsing. Okay, so more than 50% cases of multiple sclerosis, they are relapsing, they come and go, and remitting, they heal by themselves. Okay, so why they relapse? So because when there is conduction block, very soon it is repaired by the oligodendrocytes. It is repaired by oligodendrocytes. So again there, but between in these episodes of relapse, he is totally okay. All his neurology signs and symptoms are totally okay. But again he will have, after few weeks, again he will have this antibodies, these T lymphocytes will again destroy the myelination. Again he will have conduction block. So there will be again relapse. And after few days, after 24 hours, 48 hours, these oligodendrocytes will start working as repair mechanism. And again the patient will become okay. So that's why we call it a relapsing and remitting. So this is because of this, again and again there is development of conduction block, and every time it is repaired. But sooner the conduction block is more and repair chances of repair is going less. Okay, so this is the pathophysiology. There is inflammation which results in development of lesion. As a result, there is a plaque. Okay, and there is demyelination. So more axons are demyelinated. They are the myelin sheet is ripped off from the axons. So and there is gliosis, means there is astrocytes proliferation in the area. As a result, there will be plaque formation and sclerosis. And because of the demyelination, there is this concept of theory of conduction block. Don't forget this. So because of this conduction block, everything is happening all around us in the white matter. And why there is conduction block? It is because of hyperpolarized potassium channels. Okay, so this is about pathophysiology. Now we go and understand the thing, what we call epidemiology. So often, sometimes in the question it also comes, like in MCQs, it comes, it's common in men or common in women. So remember, it is common in females, are more common than men, mostly in 20 to 30 years. Also, one point to note geographically. So before, remember vitamin D is a protective. Remember this concept, is protective for multiple sclerosis. That's why those countries who have less sun exposure, okay, because when there is sun exposure, we need the ultraviolet B, UVB, we need that. So UVB, ultraviolet rays B, we supply the vitamin D. So in those cold countries, when in the summer they have less exposure to the sun, they are always in a high risk for multiple sclerosis. So that's why European countries, is more common than Asian countries, right? When there is, because in European countries in winter there is less sun exposure. Okay, so vitamin D is protective in nature. Whites are more common in multiple sclerosis. Females are more common, and apart from that, in multiple sclerosis, what you need to remember is that diagnostic feature. So one thing we have to remember here, in the whole, when this multiple sclerosis is developing here, so what happens in the CSF? Okay, so in the CSF we know this is the dura mater, then arachnoid mater, then pia mater. Okay, so and this is the spinal cord. Okay, this is the spinal cord. So remember one thing, in multiple sclerosis there is, this is called intrathecal part, right? You know that where there is a spinal anesthesia is given. There is lots of immunoglobulin G's locally synthesized here. Immunoglobulin G, plenty of immunoglobulin G locally synthesized. Okay, this immunoglobulin G, plenty of immunoglobulin G found in CSF. So we call this, there is increase intrathecally synthesis of immunoglobulin G. Normally, if you take the serum, if you take the serum here, the IgG, the present in the serum, it should be compatible. It is similar normally, but in multiple sclerosis, the IgG that is found in serum is not the copy of the IgG found in serum. So this is totally different. So that's how when the CSF study is came to know that this IgG is totally different. It means what? It means it is locally synthesized here. So there's increased intrathecally synthesis of IgG, which is an antibody, IgG antibody. But we don't know where is the antigen. But till now we know that there is high amount of IgG is found in the CSF, and that is different from serum. So when we see this IgG in the electrophoresis, we see in the some bands which we call as oligoclonal band. So which is a diagnostic feature of diagnosis of multiple sclerosis. So in CSF, oligoclonal bands are found seen in electrophoresis. And if you do the CSF study, you'll see there is increased intrathecally synthesis of IgG. But we don't know exactly why they are produced, but they must be produced because of some antigen reaction. But we don't know what the antigen basically stimulate this, which antigen basically stimulate this synthesis of immunoglobulin G in CSF. So don't forget, this is nowadays asked in most of the MCQs. Okay, what is seen in CSF? Remember, this is a CSF report. In the CSF, there will be increased intrathecally synthesis of immunoglobulin G. And when you do electrophoresis, remember this is an electrophoresis report. There is presence of oligoclonal bands. You know, oligo means few, like oligoamenorrhea. Okay, oligohydramnios, oligoclonal bands. So what these oligoclonal bands are? There's protein. Okay, that are found in the CSF. Okay, so these are oligoclonal bands. And apart from in diagnosis, you can diagnose in this way, or there is actually no definite diagnosis. Remember, there is no definite diagnosis. It's all by the clinical signs and symptoms. But if you do MRI, yes, you can do MRI. So most of the time there is a IV injection of the contrast gadolinium. Now normally this gadolinium cannot escape from the blood-brain barrier into the brain parenchyma. But we know in multiple sclerosis the blood-brain barrier is disturbed. So this gadolinium, this is a contrast agent, it is given IV and it escapes the blood-brain barrier, goes into the parenchyma and make it a contrast, and in the MRI we can see that hyper illuminating thing in the white matter. Okay, so that is also a part of diagnostic loop. So you have to remember the clinical signs and symptoms here, and we know this is remitting and relapsing, and we know what is there in multiple sclerosis. Typically involved with is SOBBC. Okay, like sensory system is involved, ocular system is involved, bladder is involved, bowel is involved, cognitive is involved, plus upper motor neuron lesions. So treatment is basically, as it is autoimmune disease, treatment is basically there is glucocorticoids are given. So glucocorticoids is the mainstay of treatment along with so many other drugs. Okay, so this is in short in brief about multiple sclerosis. So plenty of questions comes with multiple sclerosis because it is a long list of clinical signs and symptoms. So you have to remember in this fashion. Okay, so if you don't confuse it, motor neuron disease, this is not involved. Multiple sclerosis, these are involved, plus upper motor neuron. So upper motor neuron signs will be present, and diagnosis we can do deal like this. And remember, it is a relapsing and remitting disease. Okay, we end with this note that it is relapsing and remitting disease. Okay, that's why the course of the disease is very, sometimes patient only have relapse. Okay, they starts with relapse, and sometimes they have a steady deterioration of the disease, which we call a secondary progressive disease. Okay, sometimes they have both. Okay, sometimes only they start relapsing, remitting disease, or sorry, they start with the progressive, which we call as primary disease. So when we say the course of the disease, so some patients, they present as relapsing, means relapsing and remitting, which is the most commonest type of course of the disease. Some patient, after, when the most of the time patient starts relapse and remit, and in between that he is completely okay and no neurological signs and symptoms, but eventually he will go for a steady deterioration of his health. We call it secondary progressive. Secondary progressive, steady deterioration means there is no relapsing now, no attack. Relapsing means no attacks. Some patients starts with primary progressive, on just clinical deterioration, primary progressive, no attacks. Primary progressive. And some patients have both relapsing plus secondary progressive. So these are the clinical course of the disease. Okay, so that's why the disease, it differs from person to person. So you have to diagnose with your clinical knowledge. So that is about multiple sclerosis. Thank you.